I would classify skills assessments as perhaps a separate subcategory, and some assessments that are maybe combinations. What is a simulation? Are we getting at knowledge? Are we getting at knowledge and attitude also, or different skills? But I would say, the bigger categories that I see a lot in the literature, a whole class of assessments related to attitude, certainly, like the ripples and IAQ, various types of assessments. But I think the largest proportion of our assessments are assessments of attitude, and I'd like to see more related to knowledge and skills. But just to start us out.
Just to follow up on, if I could, do you have any sense of kind of practices that would help us make the link between the kind of measures of attitude, which tend to be lower on the kind of Kirkpatrick framework, to outcomes? Because again, kind of the ultimate goal here is outcome of patients. So any suggestions you have for us to at least try to, with regard to what we have, to make that link? You're
What's
good.
on? Okay. I don't know about practices. I think there are theoretical links. So there are theoretical models that link attitudes to behavioral intentions and on to behaviors. And I think an approach like that. So the author's name escaped me, one particular model of that. But I think to have a theoretical underpinning to say, okay, why will this attitude link to a behavioral intention and to interprofessional practice, teamwork, collaboration? Why would that work? And there are many different models of I think of approaches like that, such as maybe somebody can help me out. So there's like a general exposure, having the different professions exposed to each other early on in their training, and therefore that lessen some of the stereotypes of the different professions, and they understand the similarities between them, and they learn to collaborate. But those are, I think it's important to have those models, those theoretical models, in order to make that connection possible. Maybe somebody else can speak as to advances in practice that have led that to happen.
Okay. Please.
Just to clarify, are you asking for some specific examples of what we're doing?
If you have a specific example, particularly in the measurement assessment piece, that would be helpful, yes.
We're very excited about what we're doing. I'll have to say up front that we haven't got a lot of data from actual student outcomes. We're still doing what we call our pre-testing. We haven't done our post-testing, but we've validated our instruments. The premise of what we're doing, I'm from the University of Virginia, Tina Brashears. The premise of what we're doing is that interprofessional competencies, when we talk about them, are very, very general. And that if you ask your students about these competencies, they'll often say they're already good at them. They're so general that it's difficult for them to really connect those behaviors with specific clinical practice situations. So we base our interprofessional experiences and the associated assessments on clinical guidelines, and have expert panels determine what are the very specific, profession-specific and interprofessional behaviors relevant to that particular patient care area, patient population, illness experience, acuity, and they develop a comprehensive list of what they believe to be the essential behaviors for effective implementation of those guidelines from a teamwork perspective. And we call that a collaborative care best practices model. And from that model, then, you can simplify for students, simplify a little less for residents, hold a gold standard for fellows and clinicians, but basically use the same model for all different levels of learning, and derive what we call collaborative behaviors observational assessment tools. The limitation of these is they are very situation specific. So in order to be exportable, we would have to essentially export a package, which would be the case, the tool, and then the setting in which we use the tool is called an interprofessional teamwork OSCE, Objective Structured Clinical Exam. We call them ITOSCEs. in order for the tool to be valid and have integrated reliability, we tried putting 2 students in the room with a standardized patient, and the ability of those students to be assessed was so dependent on what the other student was able to do that we have gone to a model where we have a standardized patient and a standardized provider with just 1 student in the room. And the advantage of that is also is that we've got 2 SPs doing the rating. And we found that with our tools, through several, I don't want to make it sound easy, it took many iterations using videotapes of students, but we've got now pretty reliable tools so that we don't have to have a faculty member looking at every one of these, because we've got all 260 medical and nursing students going through 2 of these twice a year. So to have enough faculty to do close to 1,000 or over 1,000 ITOSCs would just not be viable. I think, again, the limitation is that it is labor intensive to create these tools, but once they're created, then you, of course, can continue to use them. But I think it really helps the students bridge that gap between what they see as an activity that's nice but not essential into really this is how we take care of a patient in sepsis, or this is how we take care of a patient in respiratory distress, or this is how we take care of a patient being discharged to a nursing home, rather than, as was talked about several times, IPE being something separate.
Mm-hmm. You had your hand up over here? Thank you.
Beth Mancini. I absolutely agree, Tina, that it's critical that we know what we are measuring for. What is the tool for? Where is it situated? Because most of this is situation dependent. And so when I first read this question, it was almost like you can't answer it from here. Do we have common operational definitions for the characteristics or the competencies that we are seeking to the student to acquire through the interprofessional educational experience? And it sounds like the work you're doing, Tina, is exactly the kind of work that I would support that we needed to do. Broad-based attitude scales, while nice, and may give us some measure, I'm not sure is going to be the next best proxy to being able to then move on to actual patient outcome, that this would be the natural next way to do it. Because until we have a large enough cohort of individuals who've gone through the process, outcome's not going to change. Just the variety, the necessity of having enough people there doing it, unless we talk about a very specific, person-specific group that's taking care of a patient, like we do when we look at trauma teams. The trauma team at this hospital, composed of these people, are able to be linked to patient outcomes. But that is the challenge, I think, in exactly what level of evaluation we want to accomplish. I would support the notion that we have to accept that right now we probably need to be at that point as opposed to the direct patient outcome.
Mark, please.
Actually, I wanted to ask a question of you, and is it Tina from UVA? So is the idea behind yours is that they're basically underlying collaborative competencies that just happen to look certain ways when applied in certain settings. So that sort of principle in theory stays the same. It's just you've codified how it looks in certain situations.
Yeah, exactly. So that, you know, we have very high acuity settings where, for example, communication is simply, were you clearly heard? Did you do active, you know, did you say, yes, I gave the epinephrine? Those very basic kinds of communication, teamwork skills, versus we have end-of-life discussions where students really have to understand the nuance in conversation over something like that with a family member. So, you know, you can describe them as the same competency, communication, active listening, respectful, all of that, but they look really, really different. And I think that's really helped us identify very specific learning objectives. And it also, I think, gives the responsibility to the students to figure out, you know, I'm okay at this, but I'm really not that okay at that. They sort of own the learning objectives in a way when they're more specific. I don't know if I said that clearly.
Okay. And then my question for you, I'd be interested in the work you and Ben Cheslick have done, and how you would see that sort of in vivo assessment and its application to what we're talking about here.
Yeah, it was. Yeah, thanks, Mark. So just to give everybody a little bit of background, we've been embarked on a project trying to measure, if you will, teamwork behaviors of the individual, particularly in the hospital setting. And honestly, the question we started out with is there an I in team? In some respects, because we weren't sure we can disentangle it. And so we went through a lot of work. The kind of short answer preliminarily is, yeah, you can actually look for teamwork behaviors using a multi-source approach that appears to be helpful to, in this case, it's physicians and changing the nature of their behavior and practice through this kind of feedback process. We've worked with 25 hospitalists, and we've just put it out for a second round of kind of testing. And we did a ton of cognitive testing with it, involving everybody from patients to all the other members of the team. So it's a very multi-source approach. What's interesting, though, Mark, to some degree, it does get at what Tina said. That particular tool was really designed for use in an inpatient setting, mostly within kind of circumscribed microsystems to some degree. What we found in our ethnographic work, particularly that Ben did, is if you say teamwork, good luck for a hospitalist, because it really depends on the institution you're in. So some hospitalists are actually, located within a confined geographic space. At Jefferson, for example, they're on literally 9 different floors. So teamwork to them isn't about working with the same group of people over long periods of time. It's about what Amy Edmondson calls teaming. And you have to form and disband teams all day long. And so the tool was really developed with that in mind, that there is a lot of context specificity around location and setting. And so it's designed with that. And it has the typical scales, but what we're learning is no big surprise, and this is the other piece I think would be interesting to hear the group react to, it's the qualitative comments. It's the narrative that's part of the tool that's turning out to be very valuable, because it describes particular examples or particular patterns of behavior that physicians find helpful. The other piece of this we're finding it to be really important, and this has become a best practice in multi-source in industry, is that you never look at your data alone. That, we require that you sit down, or we can't mandate it, but we require that you really should sit with a trusted peer, whoever that turns out to be. What was interesting in the pilot test for a number of our physicians, that wasn't another physician. It was actually a nurse that they would sit down with, because that's who they were most dependent on to get their work done. If you think about it, because when they're on, service working, there isn't another hospitalist around usually, right? They're kind of it, which is ironic. And yet, so their most important team members tend to be mostly non-physicians, what they're working with from their perspective. So anyways, that's kind of where we are with that. And I think it does tie in very much to what Tina said. It's a little bit more generic. It's not case specific, which I think you highlighted is another important piece of this, in addition to the context specificity. But we've also found we just can't plop that tool into the ambulatory space. So Ben's been working with other groups to see, could it be redesigned, but it's not, you just can't plop it in, because the context is pretty different in that setting. So I hope that that's helpful.
Thank you, Susan Skoshilek. Eric, I've puzzled over whether or not the assessment should come from practice rather than from education if we want to connect it with outcomes, because we approach the way we assess our students for different reasons. We've never really yet connected, we want to, but we haven't effectively connected outcomes. And the assessment of teams in lots of settings, but especially patient care, has its own science, and I'm sure you all are more aware than I am, but I was very struck by a presentation I saw by Jody Hoffer-Gattel, who's at Brandeis, and measures the relational aspect of the teams. And it's, you know, it's very descriptive in the way that the measurement occurs. And it seems like that could get closer to what we're hoping in the educational environment, especially as we're having the students form teams. Could we show them pictorially what do the teams look like?
Jody's work actually influenced our work quite a
Yeah.
bit when we were thinking about that. I mean, the other concept actually like either Carol's to comment on, but I think your point's a good one where you start at the end, where you think about what's going to ultimately happen in clinical practice and work back. That's what trustable professional activities are all about. You know, that we tend to start here and work forward, and we hope we hit it, right? So I don't know, Carol, if you want to say something from your perspective, how do you think the EPA concept would apply to interprofessional competencies as an assessment strategy as we're using right now within residency training? So Carol, do you want to comment?
Sorry. I think first of all, you know, it will help to get us to a shared mental model because, well, I think sometimes, you know, once you get to things like competencies and more granular things, there may be some differences in, you know, disciplines. I think at the big level, the EPA level, I think we could really develop consensus around what those might be rather easily. So I think that gets us to sort of a shared mental model, which is, to me, probably the most important thing of knowing where we want to go, what the outcomes need to be, because I would suggest that, you know, there may be some and probably a lot of commonalities as we look at our various disciplines, but there's probably going to be some discipline-specific issues that, you know, need to be tended to and dealt with, as well as some local level issues that I think need to be tended to and dealt with. Because, you know, in your institution, you may want to assess, you know, certain competencies within one setting or context, and another institution may find that it's more appropriate for them or more effective or efficient for them to assess them in another place, another context, another setting. So I think the EPAs are going to be really helpful, first and foremost, at sort of getting at a shared mental model. I think the other thing that they're going to be very helpful with is, you know, the integration. I mean, because in the end, we want to get to patient outcomes. We want to get at delivery of care so that we can assess outcomes. And they allow us to integrate across competencies, across domains, to look at actual activities that involve healthcare delivery. And so the end result then is the opportunity to look at what the outcome of that delivery was on the patient. That activity, that healthcare delivery on the patient. And so I think there's some promise with that. The other thing that, I know you didn't ask me to comment on this, but while I'm on, I'm going to just throw this in. The other thing that has just been so striking to me all day as I've listened to the presentations, and, you know, I would say assessment is a huge challenge, even just educational assessment. And then you're trying to deal with, you know, assessment of patient care outcomes, which is another huge challenge. And then you try to link the two, and oh my God, it seems like, are we ever going to get there? And I think a bridge to those two things is quality improvement. I think experts in quality improvement and some of the QI methodology around rapid cycle plan, do, study, act would be a very helpful way for us to bridge what seems to me like, you know, two insurmountable challenges, and then, you know, you put them together and you think it's just not doable. And I think our QI colleagues should be at the table with us. I think they could help us do it.
Thanks, Carol. Carol.
So maybe I'll pick up on the bridge piece. And I'm not an assessment expert, but I think about the closer the learning is to the patient care, the easier it is to measure it. So I think about that recent paper, I think it was in JAMA, about surgical teams and linking team training to decrease mortality. But for us, there's a lot of separation there, so it might need to be a series of steps. First, does the learning experience lead to behavior change? Then is that behavior change generalizable to other settings? And then is that particular behavior not in the same individual related to different patient care outcomes? So we may not be able to assess whether Carol's learning experience leads to different outcomes for her patients, but we may have to construct essentially a theoretical bridge to link what you see in the learning experience and its assessment and what happens over time to patient care outcomes.
Brent, did you want to add anything? Because you think a lot about this, so I want to make sure before we move on to the next question, if you have any reflections, what you've heard so far.
I just think about how hard this is. Having been a DVT researcher for 15 years with one diagnosis and an interprofessional team, is that we're setting up an artificial team. First of all, we have all these health professionals, and we're not even including the entire group that provides care in a hospital system. The MA, the nursing assistant, the environmental sciences folks who goes in and cleans the room, that sees the blood on the floor, sees a patient at risk for a fall in an acute care hospital setting. So we're focusing on our own disciplines and how we think communication is the issue causing the problem, so we need to have them communicate and work together better as a team. But there's a whole system they have to interact with and a bunch of other people that have not been invited to the table. And so all I can say is I agree with Carol. I think this is going to have to be done in steps. We can't on the education side say we're going to give you this amount. We don't even know what the right dose of IPE is yet. The dose, the timing, the duration. We don't have that down yet. And so what's the right dose? How many times? How often? Throughout your career, do you need it just a 4-hour simulation? Do you need, whatever? And then once we decide what the dose might be, there's many other things that are going to interfere because there are different teams. We don't have the same team. So what we train on the academic side and we place as individuals in a system to provide care, we don't go in and measure the outcomes. I mean, I can tell you right now, the outcomes aren't good what we're currently doing in the United States, right? We know that we are not doing well. So we can say we're hoping to make a difference by training this team and improve outcomes, but let's be very honest. Our outcomes are pretty bad. We're pretty low on the list of the Western countries providing health care in the world. So I guess that was not very helpful, except to say we have to assess learning. So you assess what your objectives are. So we start small, we keep building, and we look at different ways to measure team. We have a doctoral student working on evaluating team behaviors during a 4-hour simulation. It's the most labor-intensive, painful thing we've ever done. We have 72 hours of video that multiple faculty review to see if we can discern effective team communication. And just when you think it's working right, there's one member in that team, and just remember that the unit of analysis is team, that may not be a good communicator. And so what does that mean for the patient's outcome? I don't know. So we're doing some validation of tools, but how that will actually be utilized, we'll see.
Mark.
A question got asked earlier about if we can get to the same place by a different method, or I had the experience of spending some time with Brian Sexton at Duke, and I came into it from an educator model, which is we've got to sort of train everybody in these competencies. We have to prove they're competent, then they'll go out and do these things. And their approach was very different, which was simply to say, let's survey our institution in terms of safety culture. We've got good evidence to show that below a certain threshold is where the problems happen, and we're going to put our attention to those places. In fact, most, there was a small number that didn't reach the threshold. They then go there and simply say, well, they find burnout, they find depression, they find various things like that. They spend a lot of time on that. They lower the bar they're looking for. They give them some goals that are, where they can get some base hits. And over the course of a year, the goal is to see that culture safety score go up. And what they find is if they do that and help a team be successful, people seem to figure out the behavioral parts of it. And so this whole idea that you need this elaborate training method to get people to that, they sort of, that's a lot of effort to get there, and we're not sure it's worth it. So they do, they get to, I think it's 80% participation in the clinical unit that they consider a success, that they've got enough data at that point that they feel like they've assessed the culture of that unit. And so in an ICU, it is, I don't know if, for example, they include the people who clean the floors or whatever, but I think it's predominantly people who have a clinical role in the unit. So pharmacy, nursing. Mm-hmm. It depends on the unit, who's there. I don't know that I could speak for it because I don't know it in that detail. My assumption in an ICU, they'd have respiratory therapists, nurses, pharmacists, physicians, PA, nurse practitioner, whoever happens to be in that unit. Yeah.
Just a reminder to use the microphone because it's being recorded. So we're going to go to one last comment before we move on to the next piece, and we're going to go over here.
Thank you so much.
Just say your name, please.
My name is Jody Frost, and I represent the Interprofessional Professionalism Collaborative. I am with physical therapy, but actually one of my colleagues is in the room who's a part of that. This group has been working about 4 years in the process of developing a tool that assesses interprofessional professionalism in practice. It's at the other end, and we're about ready to launch a pilot beginning next year across 14 health disciplines, across more than 50 institutions that have IPE with students in their final year of whatever that is prior to graduate, whatever they call it, across a number of behaviors that are observable behaviors and across 7 constructs. It has been, there are several articles, the Journal of Interprofessional Care and the Journal of Allied Health. But the difference is it's going to be tested in multiple settings, across all kinds of settings, health professions, optometry, medicine, dentistry, physical therapy, pharmacy, et cetera, to see, in fact, the construct of what do health professionals look like when they interface with each other and the patients at the center. And so the learner coming in is going to be assessed by a preceptor, and it can be a 360 against how their performance is. And I can give an example of one of the items, identifies near misses and medical errors and reports them for their profession and on other health professions. So that would be an example of what would be interprofessional professionalism, and by and large, we don't have that currently. So we're going to see what that is. It'll take a year to validate the tool, and we hope it does prove worthwhile. It's undergone expert content reviews, 2 rounds of cognitive interviews, surveys by different multiple health professions, presentations done U.S. and internationally to try to get us to a point of testing what is the hardest sample any of us have ever tried to do across multiple institutions, contact people, multiple health professions, and in a variety of settings. So stay tuned. We think it might give you an answer to some of the practice side of what does that look like, and it could be assessed with a learner, and it could be assessed across other health professionals about how well themselves they believe they demonstrate these interprofessional professional behaviors, some of which match with the core competencies currently from IPEC. Thank you.
Yeah, thank you very much for letting us know about that. So I'd like to move on to the next piece, which is what should be the intended goals of measuring and assessing impacts of IPE across the continuum of learning. So maybe we can think of it in terms of short-term goals. I think we've alluded to that a little bit in our last conversation, and maybe long-term. So what do people think? I won't forget you guys. I keep looking. Again, intended goals of measuring and assessing impacts. Yep, go ahead.
I guess I need a little clarification on the question, because what comes to mind when I hear it is the issue of are you trying to make the distinction between formative and summative evaluation on individuals? Are you looking at it at a programmatic level or a population level? Because I could see that when we talk about the intent of evaluation of anything, we probably end up at all of those. And as we're crossing education to practice in whatever discipline, the nursing student, the pharmacy student, the social worker student, do we need to address how we help that individual get better, or how the program gets better doing what it's supposed to do? So it's just more questions rather than answers.
That's okay. What do you think it should be? So you just mentioned 3 levels of a unit of analysis. Where do you think we should start?
I would think we probably have to work through all of them eventually, but where would we start? I guess for me, probably programmatic to individual to institution might be the way to start. Is what we're doing effective as a program would help us refine how well we can do it, improve individuals, and then have the ultimate outcome, perhaps.
Thank you. Susan Skoshilak. I think the long-term goal is improving health and making sure that our asset, our collective asset of health in a country, in a community, whatever it is, improves. And if we have that larger definition, I heard others speak of it yesterday at the planning meeting as well, but that larger definition connects to all of us. So it's not even just improving things for patients. I very much agree with Carol's comments about safety and quality being one of the really important areas to focus on. But I think the longer term goal is to really maximize our assets as communities. And if we don't have that in mind, we're probably not being as inclusive as we should be.
John.
John Herbold. To stumble or stutter along with Beth and some other comments about the unit of analysis. I know Health for All is a great idea, but I try to bring things back to measurable outcomes. But I think in this case that the unit of analysis has got to be the institution. So the institution at some level. I'm reminded of the support project that looked at end-of-life outcomes. And as an epidemiologist, I use that as a case study. Everybody gets critical. The nursing and medical professions, when I bring them together to discuss it, take shots at each other. But if we want to improve, or if the goal is to improve patient outcome, then I would argue on a simplistic level that if academic health centers are involved in instituting interprofessional education, then the academic health center clinical teaching settings should be able to demonstrate that they have improved quality, safety, and patient satisfaction, and I'm going to add professional satisfaction metrics above and beyond external institutional settings. So you could do public-private, you could do whatever setting that you wanted, but if it's going to be patient outcome, it's going to have to be on the group level, and it's going to have to be not one-on-one, and not whether the health professionals are happy or doing their job, but does this intervention improve patient metrics? And I think patient satisfaction is an important one, and it's measurable, and the quality and safety. And I think from our pharmacy presentation, pharmacists have gotten very good about efficiency on delivery of their product. And so the unit of analysis, I think, has to be the institution, however you describe that, and then the inter-team variability that you mentioned about a poor communicator, then that'll be taken care of within the analysis of that. And this is a challenge to academic health settings. It's okay, we're advocating for interprofessional education. Let's show that it improves patient outcomes.
Yes, Carol.
So, I mean, I agree wholeheartedly that the long term, the ultimate goal is looking at the patient outcomes and linking to education outcomes. But I probably would start with some really low-hanging fruit, having tried to assess residents over 20 years and knowing how challenging it all is. So a couple of things that to me are just low-hanging fruit are measure, just invoking some form of measurement, even if it's not at this point reliable, valid, to send the message that this is important. I think it really raises consciousness if you start talking to learners, trainees about, assessment, because it sends a very important message, right? We value what we assess. And so that assessment may just be some formative feedback, a very sort of rudimentary or formative type feedback. The other thing that I learned from a paper, Marion Friedman Ben David, who talked about assessment as the teachable moment. So, I just would really buy into something early on that has to do with, a clinical encounter, a direct observation, sitting down with someone and delivering some formative feedback. And in the process of that formative assessment and that feedback, again, I just think you really begin to teach people, what's meaningful, what's it all about. And I think early on we're going to have to embrace qualitative, which is I think it's very hard to do. We've been, a lot of us have been sort of inculcated with the fact that, it's quantitative assessment, and I think it's really the blend of the two. And in the beginning stages, I think qualitative is important. And it just sort of takes me back to, I'm not even sure how you say his name, whether, Eric, you would know, David Snadden, who talks about measuring, we measure what's measurable rather than what's important. And
Actually, Albert Einstein, not
really?
all that
That's
can
where
be
it came from?
measured is valuable, not all that's valuable can be measured. And Snadden took basically a version of that. Right? So we tend to measure what we can. Just quickly to react, because I think it also ties in with said over here. I think part of the tension, I think, is worth calling out as a goal. Is this mostly about improvement or assurance, right? Or control, quality control. And I think that's always a tension. So that gets into the formative versus summative. And there's a fair amount of pushback now, I think, from some of the world's leaders that we're in a post-psychometric era and not everything can be reduced to a number. And maybe we need to embrace the language, the word, as a form of assessment. I think you very nicely highlighted that. Doug?
Yes, I wanted to support that as well for several reasons. I think the low-hanging fruit idea is important. We're talking about education here first, right? And we have to get interprofessional education ingrained into our institutions, I think, in some way. And to assess that and to give feedback is an important way of doing that. If ultimately we want to look at our institutions as units of measure, I think these things have to be thoroughly ingrained, and there are a lot of iterative processes along the way to getting there. The other thing that I think is really going to be very difficult about assessing institutions or other even smaller units than that is that outpatient outcomes are so multifactorial. And so then there's so many things that change over any period of time, so many secular changes in trends of all kinds, both in incidence of disease and our abilities to diagnose it and manage it, to be able to isolate. And this would be a question: do we want to try to make assessments in such a way that we can isolate the effects of our interventions, our educational interventions? That's a very hard thing to do, especially if we're looking at the bottom line, the patient outcome, as the final goal. And so I don't know if anyone's mentioned it here, but if not, let me just raise the question: do we want to make comparative approaches, or do we want to compare educational interventions and educational methods or not? That, then it leads directly into how do we design not only our assessments, but do we design them in such a way that we can compare different methods of educational intervention?
Carol, and then Brenda, then we'll move on to the next question.
I think the eventual answer is yes, we want to compare interventions and see which are the most effective, but I think we're ways from that. I actually have a question for Tina, and I wonder if you have done that collaborative behaviors assessment on faculty and staff, and are there any differences in patient outcomes for them?
The short answer is no, but the little bit longer answer is that's part of what we're working on. If I could take just a moment, We haven't put in the proposal yet, so we don't know whether we'll be able to move forward. But one of our ideas is that to leverage a CMS grant that our health system just got that has a very robust data collection system. It's called MyCourse, and patients and providers have ready access to this throughout this patient's both inpatient and outpatient care in our cancer center. And so what we're hoping that we're going to be able to do is to put students and residents and fellows and clinicians together, and faculty and attendings, and train people, assess them separately, because faculty are not going to be assessed with the students. They're just not. There's just still too much, ego's too harsh a word, but concerns about that. But so we'll have some comparative assessments if we can do that using a more complex, again, assessment tool for clinicians, a more simplified one for students, and then have that group stay together for a period of time and take care of patients in the cancer center and see them as outpatients and see if we can get both objective data, rehospitalization data, say QI issue, but also some of these narratives that patients and providers will be able to input into this system. Our biggest challenge with it is going to be, you say dose, it's also time of the dose. How long we're going to be able to logistically keep these groups together. I think we can keep a significant number of obviously fellows and clinicians together, and then residents a piece of that, and students an even shorter piece of that. So that kind of we haven't really figured out the details of how to approach that, but I do think we want to do some comparisons between students, residents, and faculty clinicians, how they respond to these things.
Just a comment from what Carol had said about low-hanging fruit. And one of the 4-hour curricula that we have around team communication using our simulation lab for 450 students every year during the medical capstone is the students do peer evaluation. So it's being taped, so faculty do the video coding and tape, doing the research around that. But then there's also expert faculty that evaluate the teams on a hand filled in form, and then there's students who aren't participating but are evaluating their teammates. The students, so far the data shows that the students that are assessing first, the first scenario, knowing that what the competencies are, communication, teamwork, and how they show leadership, have been shown to do much better by the third scenario. Now, some will say from the literature, if you do 3 simulations, you're going to do the clinical care is going to be better in the third one because you need at least 2, and 3 is ideal. But the communication with the team, the students, and their awareness of their communication, their awareness of the role differentiation and things is much greater for those students that really understand what it is we're assessing. To us, that's low-hanging fruit, and they really have gained a lot of the skills, and they didn't even have to participate. They just had to, well, they participated as an observer and an assessor. So
Helps to know what the target is. Yes, could you use the mic, please, and then we'll move to the next one.
I have a question of both of you, and that has to do with when you're talking about students, I'm not hearing interprofessional from what when you're talking about, and so I just wanted to get some clarification. Madeline, you talked about residents and fellows, but at one point you talked about also looking at nursing students and medical students. So when you get to the resident fellow level, are you looking at other professions as well, or are you simply looking at the residents and fellows?
No, I'm sorry. I called graduate education. I didn't mean to say residents and fellows. When I say graduate education is the term I meant to use, so I mean nurse practitioners as well as residents. They'll all be working together in this model, so I think distinguishing some of the interactions is another challenge. Who are you working the most with? But we have plenty, especially with our acute care NPs. They round side by side with the residents. They do much of their training together, so I think we'll have a group we can look at there.
Okay. And
we have 2 different groups. When I say students, I'm referring to our BSN, our PharmD, our PA, and our medical students. We've mapped the curricula so we have different levels of those students that have learned the same thing. And then we also have advanced practice, which are more the acute care nurse practitioners, DNP with the medical residents in the primary care center at the VA.
You know what, I'm sorry.
Very brief.
Okay, go ahead.
Does anybody include social work students in their?
Well, we just got another grant, and we will be including social work. So the studies we've done have been all grant funded, and it's mainly focused on medicine, nursing, pharmacy, dentistry, and PAs. But we are now adding public health and social work students.
Did you have social?
Not at the clinical level, but in the classroom level, doing problem-based learning.
Yep. Okay, the next kind of question, what do you believe are the needed resources to effectively measure, assess IPE impact across a continuum of learning? So I think we've heard a little bit about that so far. Time is certainly a really important resource, always is. What else? What else do you think we should be paying attention to around the resources around measurement and assessment?
Hi, Kathy Rugen. I'm from the VA, and in our centers of excellence, a lot of our evaluation is qualitative, and so it's having those qualitative experts, and then the time it takes for transcription and analysis of that quantitative data is long, and it takes that expertise. But I think someone mentioned here that that is the majority of our evaluation.
Two different perspectives. One is, of course, the common operational definitions of the variables in which we're going to measure and ultimately the tools that we're going to use, because it will be hard for us to generalize against one facility, so we'll need multiple facilities doing this. And the other is a question, will it be different when we talk about the continuum of learning when we move from the educational program to the true practice environments? So those practicing social workers, physicians, nurses, therapists in an ambulatory setting, when we want to measure that, is there anything distinctly different than when we're talking about in a structured learning environment that we've talked about so far? I think there probably is. There are differences. I'm not sure I could articulate them, though.
So I'm struck as we talk that we have a lot of people to assess, students and practicing clinicians of all stripes, and that we have a need to do it iteratively over time. And I come back to the fact that we live in a technology-enabled age. We have clinical screening tools that actually are very simple. 5 questions to determine whether somebody's depressed or not, and then if they answer yes, then we sort of break it out in there 36 questions. And it makes me wonder if there's not a way to automate some of this, and to take sort of the model that the ABIM did. And I mean, if you simplified it and say, are there 5 or 6 behaviors, and if 10 people around this person say they get 5s on everything, you're done, and we've got a collaborative, a competent person. And if a certain critical mass of people actually say no, they flagged it here, then we get a branching, and all of this is done electronically. So if I've got to assess a student, I simply come up with 12 email addresses of the people who have been around that student, and they have to fill it out. And when we get 80% of them back, then we've got a valid assessment, and we move on to the next one. It would be quite inexpensive, and we could assess an awful lot of people that way.
That's your name, Erin?
Yeah. My name is Erin Abarish, and I would love to see a more clear trajectory for people who are doing research as students, either into postdoctoral positions as well as research assistant positions on grants. I know students are involved in a lot of the work that people are doing, but it's not necessarily clear from a student perspective or from somebody who's interested in continuing to do this kind of research at the postdoctoral level where one goes with that.
Respond to Carol. I think your point's really good. And Carol and I've actually had this conversation. I think we're particularly bad in the United States about collaborating and connecting. I just spent a couple of days in British Columbia where they talked about working across the 17 medical schools and the stuff that they're doing. And I'm like going, geez, I can't think of too many examples in the States where that actually happens. So I think your point's a good one, and then having a clear roadmap would certainly, I think, be helpful. Also just want to build a little bit on Mark said. I think the other thing is I'm really struck about how clever some students have been in places just using things like iPhones, iPads. Geez, what a thought. Where they have simple tools, not only for caring for patients, but they can actually fill out stuff that then gets fed into kind of a central server that are just kind of point-in-time observations that are still valuable. In the portfolio process that Jean talked about and other places used very well is a wonderful example where there are ways to collate that in very meaningful ways, and it doesn't have to be a really fancy, they're important, those fancy psychometric tools. I work for an organization that makes those. But like you said, sometimes low tech is good tech. Yeah, Carol, and then Doug.
So one other resource that I think would be very helpful is access to, whether you want to call them developmental evaluation people or realist evaluation experts, simply because this fits well with that theory. It's such a complex problem issue that, and I think Carol A. talked about sort of stepwise, and that's really how they look at the evaluation process. It's not about we're at A and we need to figure out how to get to Z all in one leap. They really make a point of recording context and, what happens as a result of that particular context, and then make the decision from that step to the next step to the next step. I just think that might be a better approach for something this complex. And I think there's another person who I love to read when I see something by him. It's Glenn Regehr, who wrote an article called It's Not Rocket Science, and it was about medical education. And he really speaks to the fact that medical education is not about randomized controlled trials. It's really about, learning from each other about what works and what doesn't in any given context. So that if we were to, I think, be more explicit about, the sort of local environment, why we think something worked or didn't work with that environment, and publish those sorts of things, others would then be able to look at that and say, well, we have an environment that looks like this, or we don't, or we may be able to take this piece and adapt it. And so maybe that's a direction.
Well, it's really interesting that you made that comment, because by my previous comment about do we want to be comparing educational methods, I really meant to imply that that's going to be very difficult to do, and it may not be a worthy goal at all. Rather, to learn to become more qualitative and to learn from each other's best practices. Everything has to be adapted to our own institutional environments. But the other comment that I was going to make when I raised my hand is I'm not involved in patient care now in the days of the electronic medical record. But when we're talking about tools and information technology tools and the whole field of informatics, are there examples of building these kinds of not only assessments but prompts within the electronic medical records to make sure that the kind of interprofessional care that we need is actually being provided. You all can educate me about that.
We're about to launch a contest for the health professional students to come up with an app for tracking the dose, timing, duration of IPE. We know the events that we schedule, we know the courses where it's integrated, but what we don't know, because we can't control where they're placed, because we have thousands of students that are being placed all around the Pacific Northwest, is are they experiencing this in practice and then sending out URLs to provide evaluation of the site, and then do some reflection of the learning. So some of this would be evaluating themselves or doing their own assessment, and I think that's a value. And the other thing, we've had students evaluate faculty, Mark, so be careful what you ask for. We can assess them and score 1 through 5, but we asked students this first year we were developing all of these trainings to evaluate the faculty who developed it, and we got some pretty lousy scores. We thought we were being interprofessional, but they gave us feedback that we weren't working together as a team or communicating as well as they thought we should. So.
I'm totally shocked. I want to build on that theme, because one of the things that I've been struck by, and I think part of the competency-based movement, is that we've always looked at assessment measure as something we do to somebody, right, and then feed it back. And there's certainly a need for that. But it should be something maybe we do more with them. And in that context, we're also talking a lot about we need to be more self-directed. In fact, the other thing, bringing back Glenn Regehr and Kevin Even, in another paper I love, they talk about self-directed assessment seeking. So does anybody have any thoughts about that? I mean, what would self-directed assessment seeking look like in the context of interprofessional education that might be a very useful activity? I'm just curious. It sounds like you have one from kind of tracking the experience, but I just want to throw that out there because we always tend to think about something we got to do to them, but maybe there's something we can give to them instead, and they could do some of this on their own. And I'd love to hear from you, Aaron, because being a student and Reese, I'm just kind of in the context of the panel we had, if you have any thoughts on that, if you don't mind just reacting to that.
I think some of the places where I've seen that be most effective is in the use of debriefs that either start with some of these more structured tools that Brenda was talking about where people assess themselves and their peers, but then they actually talk about it. And we've had observers sitting in on those discussions and seeing what it is that people have to say. And so it's this sort of iterative process that people are going through where they're reflecting on their experience, but they're also hearing other people's reflections. And so you're getting an assessment, but they're also learning from the process.
Hi, Stephen Chen from the University of Southern California School of Pharmacy. We had an elective course that had some IP involvement, and we decided not to use Blackboard. Instead, we created a blog, and boy, the students loved it. And I know this is highly qualitative, but the information that was shared was so remarkably profound and interesting. And it just goes to reflect this age of students that we have today. They like to do blogs. They don't like Blackboard as much.
Can you say more about how the blog, from an assessment perspective, was it helpful in that regard and how the information was used?
They were required to submit comments, I think at least once a week during this elective course. And so you'd see some of the initial observations that were just shocked because they're in safety net settings for the underinsured and uninsured, just stunned at what they were seeing, and then slowly begin to understand that, I shouldn't be so shocked. Some of these people had jobs, last month, and now they're here, and it's unfortunate. And it just gives them a whole different perspective on who these people are and how they should approach caring for them.
How did you use that from an assessment perspective or feedback to them? I'm just curious.
We, to be honest, we didn't formalize that. This is our first trial going through it, but we shared the blog comments in our weekly meetings and got discussions going about them. So we didn't do one-on-one assessment with that, unfortunately.
Hi, Kathy Rugen again. So in our VA Centers of Excellence, we have developed a competency tool for specifically the nurse practitioner fellows. They're post that graduate from their master's program. They're licensed and certified, but they're doing a one-year fellowship. So we've developed a competency tool that really measures their ability to work in team-based patient-centered care environment. So they assess themselves within the first month, at 6 months, at 12 months, and their mentor also does an assessment of them, and then they come together at those time frames and discuss where they're at. And we've only gotten the time one so far. We're going to be doing the 6-month evaluation in December and January. That they're really at a different place from where their mentor is rating them. So that's been somewhat interesting preliminarily.
Please. Can you say your name, please?
Mary Barger. This was not in IPE context, but for our midwifery students, they did the same thing. They did self-evaluation and had their preceptors evaluate them and then compare. But the most successful students were the ones who felt open enough to ask the medical assistants and the other people in their setting to give them feedback. And one particular student from rural Maine went to an black inner city area of Boston, and she clearly knew that she didn't look like them, she didn't talk like them, and yet freely said to them, look, I'm going to make a lot of mistakes, and I want you, when I make a mistake, to tell me, and I want you to feel free to and so she openly asked everyone from the secretary to the medical assistant, anyone who could observe her, observing patients. And I think that's ultimately where we want people to be at self-assessment, right? That they have the confidence to say, I'm going to make mistakes and help me learn how to be a better provider. And, how we can inculcate that in our students is probably our ultimate goal.
Yeah, that's really helpful. I mean, the self-assessment literature is very clear. You cannot do this in isolation because none of us are accurate at doing it. You need input. And there's also literature that shows exactly that your better students are harder on themselves and they're more likely to seek it out than those who are struggling. Susan.
I wanted to mention methodology that we found useful at Wisconsin by Hardin Coleman in counseling psychology. And it has to do with electronic portfolios and self-assessment. Had to do with designing the rubric first, but in terms of the higher order learning, when you have, in his case, students that go out for practicums early on, then they go out again. And part of what the rubric is they're asked to read their own writing from the earlier and then reflect on what did you learn now that you didn't understand before. So I thought that perspective of self-assessment, of self-assessing your growth and doing it in an electronic blog type portfolio was a great methodology.
Terrific. By the way, Cleveland Clinic does that with their students, and they have found that about a quarter of their students actually change their career paths based on what they learn about themselves by looking at their own progress. Very powerful. It's just amazing to watch, and it's all tracked for them. It's a story. Yeah, please. Mohammed, please. Yeah, Mohammed, you should come and sit up with us. Grab a chair and...
I'll just comment quickly before I join. So this point is a very good one in that we may have something to learn from business schools. Exactly the point that you just made, where they work in teams again on case-based sort of problems. They then also have self-evaluations that they go out looking for, which are these global 360s. And the global 360s will involve not only your own team evaluating you, and you're told specifically to pick people within the team that you get along with and you think you're going to get a great assessment from, and people that you probably don't get along with and whom you won't get a great assessment from, so that you could actually improve those attributes. And then there's the question of get assessed from your consumer, in this case our patients, and your mentor. So it's literally that 360 idea. And again, pick patients that you think are going to think you're terrible, and pick patients that think you're the next best thing to sliced bread. So that combination actually is pretty useful. And again, the ones that come out and look for it in MBA programs and executive education programs are the ones who are looking to be the next leaders and the next best things to slice bread.
Okay, why don't we, I'm just cognizant of time here. Thank you, Mohammed. Please come join us. Pull your chair up, please. And same for the folks in the back. I think we've had a chance to, this is kind of cross-cutting, but the next one is challenges, not that there are any, to effectively measure, assess IP impact. So I think they've come up, but is there anything people would like to add around challenges that you haven't heard come up that we should be careful to capture? Mark, please.
This, to some degree, cuts to the last comments, but this, I don't know how to articulate it, and I'm going to stammer here a little bit, but it strikes me that there are, and everybody's alluded to this, there are the sort of mature souls who seek out assessment, who self-assess, who are and then there are those who are very well defended against data that, because most people say, most people believe they've worked this out, they're good collaborators, and so so one of the challenges I think is that we're really talking about a smaller subset of people and who actually need hard evidence that they're not effective, and they're not going to get it with self-assessment, and particularly those who are in positions of authority, they're unlikely to get it from peers, and if they do get it from peers, they're well enough defended that they may not accept it. And it strikes me, if we were to really drill down to a group of people who most need this and we're really directed, this is probably the group we're talking about. And so the question then becomes, how do you, what data do you present to somebody like that breaks through the defenses such that they're open to and receptive to the information?
I'll just react a little bit. Had a little bit of experience in this. I mean, there's actually a nice literature on dealing with physicians in difficulty. For example, there's a center at Vanderbilt where there's actually a trigger tool that, and they've actually contracted out to a number of centers that once a certain number of patient complaints come in, it triggers an action. And they use peer coaches. And what they do is they provide the hard data. This is how you compare to your peers. You're an outlier. And then the peer coach kind of basically leads them through a structured conversation, trying to be very neutral to begin. In other words, not starting out judgmental, like, listen, you're a real jerk and we got to fix you. But try to explore that with them. And they've had a fair amount of success with it. So there does appear to be processes. I think it's a human process. A lot of times the first time they've heard bad news because nobody's actually told them before. So it's often striking when you talk to them about this. I liken it to a grief reaction. Having done some work with problem residents, for some of them, they don't have insight because nobody's bothered to help them get the insight. And so they have to work through their anger, denial, and depression first. They will bargain before they can reach acceptance. And it takes time. That's the other part I think we lose sight of. We think it's just going to happen overnight. Listen, here's your data. You're not doing well. You should get it today. And they often don't. On the other hand, there's a body of literature from psychology around insight, and there are those who just never seem to be able to attain it. There's a nice body of work by Kruger and Dunning called Unskilled and Unaware of It. In that what they have found that there is a group of individuals that what they basically say you can't fix in the context of the work they're being asked to do, and honestly the best solution for them is to change the nature of their work. And so I think there's both sides to it. So that's, I don't know if that's helpful, Mark, but that's a little bit of the literature I'm aware of. Are others aware of other stuff? Okay, getting back to the challenges. Yeah.
This is a much more micro challenge than these larger challenges you're talking about, but I was thinking about some of the discrepancies between self-assessment. We find that a lot of the attitude scales that we use for self-assessment actually are not only not very helpful because students know what they're supposed to say now, but actually in many ways counterproductive, because when I look at them, I'm a physician, but I teach in a school of nursing, and when I look at them, I immediately understand that they were not written by a physician, because no matter how hard people try to make them objective tools, they come across pretty negative. It's pretty like, prove to me you're not a jerk, most of these. You know, we really think you are, so if you answer this right, maybe we'll change our minds. Is really, I mean, I'm just being honest with you. That's at least how many of the medical students interpret them. Another challenge that we have is that when we have objective assessments, you definitely have to put quotes around the word objective. Our students rate themselves much better than the SPs do, as a rule. But the SPs are also really interesting in how they rate students. We have, of course, a core group of students who are really good at both the profession-specific and the interprofessional skills, the stars. We know who they are. And we know the students who are going to be lousy at both. But there's quite a few students who are good at interprofessional, but really not so good at doing their profession-specific skills, and vice versa. And what we found with our SPs is they will increase their ratings of the profession-specific skills if they like the student, because they want them to do well. Do you know what I'm saying? Yeah, and I can clearly remember one moment when, you know, I was looking at the objective scores, and clearly the student hadn't listened to the lungs without listening through the gown, you know, hadn't asked some of the specific questions that we wanted on the history, hadn't listened to the heart. I mean, basically did a terrible job on the profession-specific skills. And the SP was quoted as saying, "But that was the best student I had all day," because the student was really nice. You know, so that's one of the challenges where we're trying to sort out, you know, how to really get objective. So we do have a 360 in the sense we have student self-assessment, SP assessment, and then we go back and look at the tapes as faculty, not 100%, but do a lot of quality control.
I haven't had a chance to, you know what, I was just about to say, we haven't had a chance to hear from some folks, so this is terrific, and I'm quite fond of your shop. I'm a huge Linda Hedrick-Leshall groupie.
Yes, I
Les Hall, by
have.
the way, was my chief resident when I was an intern. So I'd
Oh,
love to hear from you.
excellent. Yes, I have many fabulous mentors at the University of Missouri. I'm Carla Dyer, and would agree with many of Tina's comments that our students really feel like they are much better at this. And with the attitudinal surveys, they rate themselves high. We can show a statistically significant difference in improving some of their attitudes and self-reported knowledge about their and skills, but they already start at a very high level. So one of the things that we're working on in the third year is we have a patient-centered OSCE where we look at, came out of a Stemler grant that one of our associate deans had, and looks at observable behaviors that are focused around patient-centered care. And we're starting to integrate some of the interprofessional education around that same model and taking some of the IPEC competencies and choosing a few and looking at what observable behaviors can align with each of the competencies, and then developing scenarios where the standardized patient and the faculty can then say objectively, did the student indeed meet those, even if they were a very nice person, or did they not? And I think that making that, those sort of observable behaviors as part of a 360 evaluation, that we can have the student perspective, but then also patient and faculty are very important. But at the same time, not discouraging people from drawing this link to quality and safety that Carol and others have mentioned, because it is messy, it is incredibly difficult. We don't have great outcomes from what we've done, but yet you are showing the students that their ideas and their time and their energy is going towards improving the patient care. And even if it's a small outcome that you can show while you're working on perhaps the more measurable piece about these skills and their attitudes, you're still encouraging them to stretch forward to try to reach the patient outcome side of things as well.
One of the tools that we used not too long ago for our clinical simulations, we did a pre and a post test, and in the post test we asked people to compare what they knew before to what they thought they knew before, or what they knew after to what they thought they knew before. So using them to, they had done a pre-test saying, here's how I rate myself on these skills, and then they did a post-test saying, here's how I rate myself on these skills, and here's how I rate myself compared to where I thought I was before. And I think probably there's sort of already rating high and then rating higher on top of already rating high. But there was movement in those things where people who did think that they were doing quite well before said, actually, I wasn't doing that well before, and now I feel like I'm doing better. So it's not perfect, but it does show some movement.
Yeah, techniques, I call it a retrospective pre-post,
Yeah.
actually can be very valuable. We haven't had a chance to hear from you. Is there anything you would like to weigh in on? I just want to make sure we give everybody a chance to.
It's all said. Okay, well, André Jacques Nazi. No, I am really, it's a very enlightening discussion for me, and also a little bit confusing. Because let me try to articulate my concern. I think that we are talking about evaluating, assessing competencies during the educational process. But maybe as a suggestion, we should really go from the other way around, from the practice side, and go upstream. In other words, we know what are really the desired outcome for any given health condition as health professionals. So if you go back upstream, you can really look at any given disease entity or health condition and think about really what are truly, we speak about interprofessional practice, and before that, of course, interprofessional education. We should really think about maybe really, we heard about task sharing. How do you achieve those desired outcomes? And what are the tasks required? So now if you go back upstream again, and I heard you were talking about the unit of analysis, which is really the institution, or you might actually start thinking about really how the various health professionals can improve their performance through interprofessional practice, and then maybe assess that and learn these lessons to bring back to the educational enterprise. So I was really thinking from the other end.
So can I just, I want to make sure I understand. So your suggestion is we should be assessing actually what's required with regard to interprofessional care, education in the practice base, and then bring that back, and that should be informing what we do in our education, not the other way around. Was that correct? Okay, terrific.
Two quick other challenges. I think one is to, over time, identify what are the signal measures and then stop doing other assessments so that it becomes really efficient as well as effective. And then the second one is, I think there's a different challenge in trying to measure behavior, because if the behavior doesn't change, it may not mean that the educational intervention isn't effective. It may mean that we haven't also taught strategies for changing one's behavior. And we haven't really mentioned that, but I think those two have to come together.
So I went to visit Hopkins and met with Peter Pronovost, who I have utmost respect for, doing the checklist and doing the the quality and safety that they do, and looking at their outcomes and thinking, how can we replicate that? And one of my questions to him was, and what is the purposeful team training that you do to get your teams to work together so well? And he said they don't do any team training. So then I wondered if I was in the wrong business, because I've been spending the last 5 years thinking I need to train these students to communicate well so they can improve outcomes. And he said, well, that's a good idea. We should focus on that. But so they're focusing on tasks within individual professions, but they're not focusing on team skills. But they work really well as a team. You just have to look at their outcomes to see. So I'm not sure how that's assessed.
Well, I wonder if that's part of the challenge that Dr. Thier gave us this morning, right? Test some of our assumptions that maybe through the preparation for the task, the teamwork behaviors are occurring as part of that process. Be interesting to kind of see. Yeah. Please, in the back here.
Can I make one quick comment? So the guy I mentioned at Duke did the research for Pronovost. So their assessment was a cultural level assessment.
I see some similar to Jean Nagelkirk from Grand Valley State University. I see similar challenges that the gentleman over in the corner see. When I look at assessment, I think of education and practice, but ultimately we do need to look at the triple aim: better care, better quality, lower costs. And one of the things we will have to look at with IPE is what is the cost of care and the efficiencies for care. Because if you're not improving quality, improving safety, we know all the errors in the hospitals and the large cost to our communities financially and lives, as well as the other thing that I think we need to move towards is population care. Are we educating our health professionals to do population care? We can't do individual care. It's just not effective or cost effective. So what are those measures to look at those three quality indicators: patient safety, cost, population health? And then a new thing is emerging, in Michigan at least, that there is such a crunch on clinical placement sites. How are we going to educate our students without paying for these? Because how much can students pay, or institutions? So what is the type of clinical placements that we need to look at in the future? And I think it does need to be IP clinical placement teams. So I think there's a whole bunch of assessment measures that we need to look at the practice end, and look also then back at our educational piece. And one other thing, the other piece, we received a grant, a NEPCR grant, a Nursing Education Practice Quality Research Grant. Michigan Department of Community Health is the lead sponsor, but we're the program director at Grand Valley. When we got on the phone call, because it's a grant where we speak every month with all the grantees, I wanted to know a standardized measure for certain pieces, because I think the most impactful and powerful would be to standardize some measures, and let's all do the same thing so we can compare our studies and see what true outcomes have. we have such variable outcome measures, we're not really standardized. So are there a way, or is there some, to just do some of these so that we can compare each other?
Thank you. I think, Beth, you had brought that up earlier as well. I want to give you an opportunity because I've been cognizant that we haven't heard as much from you, so I want to give you a
that's
chance.
okay. I mean, I'm Darla Spence Coffey from the Council on Social Work Education, and I've actually done exactly what I wanted to do today, and that was just listen to people talk about assessing competencies. Social work moved to competency-based education, I don't know, 3 or 4 years ago, and we're still very much struggling with the assessment. And so the interprofessional just is another whole layer to that. And one of the challenges that we have is that a lot of the educational programs toss the assessment of competencies to the field, to the internship, to the clinical setting. And we now need to do lots and lots of education around with those folks, you know, because to just toss the burden of the assessment of competencies to an overburdened system is just, it's irresponsible. And so and I know that many of our programs are explicitly interprofessional, but the implicit curriculum in the program as well as in the practice settings is not. And so we're really struggling with that as well. Because the implicit curriculum, I'm convinced, just, you know, it trumps the explicit every time.
Yeah, one I didn't hear that I wanted to add myself was, again, faculty development. If we're going to use a lot of these on-the-fly, point-of-care observational techniques, we need a educational workforce that understands what they're looking for, has shared mental models, have a clear idea of what they're being asked to look for, not overburdening with that looking for too much. We in medicine, as Mark probably knows all too well, are really bad about that. Yep, when you're on that rotation for weeks, do all 6 competencies. I don't know what they're supposed to look like, but evaluate them nonetheless.
Oh, great, yeah. John Tegzis from Western University of Health Sciences. Very enlightening discussion because we struggle also with assessment. And I work primarily with first-year students from 13 professions, and we do problem-based learning, small group work with our first-year students across all professions. And new this year, we decided that we were going to assess them on knowledge, actual knowledge, a multiple-choice exam. And we gave it first as a pre-test before they started the IPE curriculum, because some of these things, when we talk about communication, collaboration, again, students self-identify, already know how to do that, and we wanted to just test, do they understand scope of practice of multiple professions? Do they understand what an open-ended question is? Do they understand some of the team steps, competencies? And we were a little bit happy to find that they did overwhelmingly terrible before the course began. So we're like, great. They don't already know they don't know this already. We do need to teach it to them. We do need to go through the process. Again, now we're facing the challenge. We're in the process of doing post-test after the first semester, and they're improving overall, but they're not improving at the rate that perhaps we wanted, and they're also pushing back quite a bit now because students react to assessment. And if they aren't getting A's in it, they feel like there's something wrong either with the education or with the way that we develop the program. And we're just looking for improvement. So we're really trying to struggle. And because we're doing this in a PBL format, it's really very student driven, student directed. And some students will do well and others won't, and dealing with those too. But I think I'm very encouraged that at least we can start to measure knowledge. And again, it's not perfect, but at least it's another data point that we can start to look at and see, are we actually improving their knowledge through the IP program? And then we hope, because we have a 3-year program, our students will still continue to do IPE in their 2nd and 3rd years. And there we can focus more on skills and behaviors and see if that knowledge actually translates to anything as well. But I'd be interested to hear, is anybody else measuring actual knowledge as well? I haven't met too many people that are doing that yet in their IP curricula. And if you think that that's a worthwhile endeavor, should we even be doing that in that format?
Any thoughts for John? Yes, in the back.
I'm Julia Todutka from CGF&S International. I think that in terms of interprofessional education, it necessarily involves teamwork. And when you have that goal in mind, it necessarily have to deal with many of the issues of diversity. that the individual would bring to the table, particularly that I think that we are all in the process of encouraging our healthcare workforce to be as diverse as we possibly can. And that's a very important goal. So I would like to think of it as being a significant challenge if all our assessment is being confounded by variables that might have something to do with the background of the individuals, the values that they bring with them, the increase in diversity among patients, and the effectiveness of IPE in the context of that broader concept of diversity. And I think it's an area that we need to pay some attention to. We also have medical professionals and healthcare professionals coming from other countries that were not educated in the United States. And they're part of the team of healthcare providers. How do we address them? And how would we consider that in the context of the younger people that we are training through the more traditional framework, and yet they bring very different backgrounds and experiences. And sort of the concept of the appropriateness of protocol from their own culture. Does that mean that they are not working as a team? May not be the case. So maybe we need to learn a lot more about those variables as we begin to do this work. And I hope that that particular agenda is not lost in this conversation.
Thank you. I'm cognizant of time. Patricia, I think we had till 4, is that right? Okay, and I have 4:03. So I want to give people a chance for a quick break. Thank you very much. I have pages of notes, so this I'm sure we'll be able to put something on the slides, which we will get to, Patricia. And again, thanks for everybody's input. This is very helpful.